Welcome to the Long Term. I'm Ty King, and this podcast we've been learning so much about recovery. I think from the point that we started, there was just so much that we assumed that we knew, but we didn't, and we found that out along the way. Right? It's one of those things where you start out knowing nothing to thinking you know everything, and then finding out along the way it's a vice versa situation. And it's always a great pleasure to talk to people that are in the field that are, sort of the people that are, I say boots on the ground. It sounds so, militaristic or whatever, but like the people that are like dealing face to face with the ones that are going through recovery and addiction problems from the people that are suffering from the addiction and the ones that they affect to their loved ones, the people that care about them. They don't want to see them in that same state of mind. And to getting to talk to people that have such a deep and experience and understanding of how it all works is always just it's a pleasure, but it's one of those things that pushes us forward a little bit further down the line of knowing more about how this all works, where the holes are, what we can do to make us a holistic sort of solution. And so I really look forward to talking to Dr. Sarah Church today. Thank you for being on the show.
Yeah, thanks for having me. I love your curious approach to it.
Absolutely. I got told that last night too. We were doing a live podcast on stage, and one of the guests was like, "You're a curious person." And I'm like, "It's kind of my job, I've got to ask the questions. But I'm good." I was like, "Yeah, it's boring to just assume you know everything. Um, Awesome. So, yeah, Dr. Church, you have quite an extensive background, like we were talking about. So, you're the founder and executive director for Whole View Wellness, which is a clinical psychologist who you've had more than 20 years of experience in research, program development, and treatment of patients with substance use, and co-occurring mental health disorders. And you're an expert in cognitive behavioral therapy and community reinforcement approach, which I'm curious about that one, and contingency management.
Yeah. Well, we
Yeah.
use a lot of different techniques at Whole View. We integrate lots of different techniques depending on the person and what we think might be helpful for them.
Yeah. Because, and we've said this a million times on the show because we've learned along the way that there is no blanket, one size fits all type of approach to this, right? Not one mind matches another mind, and it kind of has to be on an individual level. So, yeah. So I guess let's start with, how did you get into this work in the first place?
Yeah, I kind of stumbled into it in a way. I was in I was in graduate school in psychology, and I needed to apply for internship. And at the time, a lot of people weren't getting internships, so they told us we had to apply to 20 of them, and two of them had to be outside of New York City, which for me, I didn't really want to leave New York City because I was sort of I'm a hardcore New Yorker. So I figured if I had to leave the city, I wanted to go somewhere like really good. So I applied to Yale School of Medicine, and I got an interview, and I figured I'd go. And when I went on the internship interview, they had different tracks, and they had a substance abuse treatment track. And I looked at my resume, and my resume was most aligned with that, given sort of the experiences I'd had for externships. So I just applied to it, and I just immediately really loved doing the work, and immediately knew this was what I wanted to do for my career, and that's sort of how I got into it.
Yeah, your credentials are really impressive. I know. So you went to Yale, of course, first of all, which is one prestigious college.
Yeah, I went to Columbia undergrad actually,
You went to
and then
Columbia.
Fordham
Okay.
for graduate school, but I did my internship at Yale.
Okay. Okay. Great. Your PR person sent me something where you had been some school that was named after Albert Einstein, and I was like, that's good enough for me.
I worked at Albert Einstein College of Medicine for gosh, I think 12 years. Yeah.
Gosh, that's incredible. So you were kind of looking to intern, and you fell into this. And did
Yeah.
it strike your curiosity, or like, did you see a role that you could possibly fill, or maybe
Yeah.
meaning? Yeah.
I had a really like I had an aha moment when I was running a group with a woman who was a marriage and family therapist, and it was a group for impaired nurses, and they were all women at the time. And when we came into the group, she would do a genogram, which is basically like a map of all the people in their family and their mental health struggles, their addiction struggles, and sort of she would map that all out, and she would do it on a big piece of paper. And then when we went into the group, she would put up everybody's genogram behind them in the group. So we were in the group, and then their families and all the people that sort of came before them came into the group with us. And they did, yeah, when I went into that group, they did my genogram, And they all of a sudden, it just became very, very clear to me why I found this so interesting, because everybody in my family had some kind of mental health or addiction problem. And it was like, an aha moment for me. Like, there's a reason why this is so interesting to me, but it hadn't actually occurred to me before that.
I found that with so many people, myself included. I've talked to other people who have, if you talk to people that have lived experience, right? And if you go to like the behavioral health conferences where there's a lot of people that have lived experience, like we're considered normies because we didn't ever have that substance use addiction, right? And so talking to all the other normies that have like such a passion and they built a huge career off of helping other people, I asked them the same thing. It's like, did you have any sort of self-realization or anything about your own past or learning to them? And they're like, yeah, not at first, but along the way, I've realized a lot about. And I was like, yeah, same here. My father was a avid alcoholic, and like if there wasn't money for anything else, there was always money for alcohol, and so he was very abusive and all that stuff. But I didn't think of it as like, he's addicted. You know what I mean? It was just like, this is life, and I've got to survive up until I was well into my adult years, and then even doing the show, even starting it out, I never even made the connection in my mind of this could possibly be part of my curiosity of like why I want to learn about recovery until along
Yeah.
the way.
Yeah.
And yeah, it's been pretty wild.
My father was a 3 martini at lunch, take a nap in the vault at the bank kind of guy. So
And did he work at the bank?
yeah, he was a banker.
Oh, okay, good. Yeah.
Yeah.
Well, at least he had access to it. Yeah.
Yeah.
Yeah, that's incredible. So, like, I think it's just another way that we sort of all benefit whenever we do, support, recovery. We kind of figure out everybody. You throw a rock, you're going to hit somebody that's affected by it somehow, some way.
Yeah.
Um, so you talk to a lot of people that are both in addiction, but also you talk to the family members and loved ones of people that have addiction. And so, is there a different approach that you take to the two different types of people that you come in and interview or you help out?
Yeah. So we use a lot of evidence-based practices. So one of the things that in my career is that I started when I was at Yale. We did a lot of research studies through NIDA, the National Institute of Drug Abuse, and those studies were developing both therapies and also medications, testing different things to see what really helped and what worked. And so I come from a research background, and then I moved more into doing therapy and doing program administration. And so when we use different techniques, let's say at a whole view, we always try to use things that we know have been proven to work and to help. So, when we're working with patients, I use a lot of different types of therapies. I might use motivational interviewing or cognitive behavioral therapy to start giving people skills and strategies to try to understand what's going on in terms of cravings and triggers and things like that. And then often we use some manualized psychodynamic techniques or some manualized treatment maybe for trauma or for other co-occurring disorders, depending on what's going on for the person. So we really individualize treatment very much depending on what we think is driving the substance use. For the person, we call it the identified patient, for the person who's struggling with substance use. And then for the family members, we use a therapy called CRAFT, Community Reinforcement and Family Training, which is a behavioral therapy that teaches the loved one skills and strategies about how to talk to their loved one about their substance use and how to handle it when they maybe return to use or have a slip or a relapse, and also how to set up contingencies to reinforce the good things that they're doing and to sort of ignore or allow natural consequences to occur when they might make a poor decision. Um, and then also self-care for the loved one, because it's really stressful to have a loved one who's struggling with alcohol or drug use.
Yeah, it's very important that how you, I guess, address and talk to someone. We earlier this week I had another interview with somebody else that was addressing that, talking about if your spouse is addicted or they have some sort of substance use issue that you've known about in the past and they're trying to do better or whatever, like threatening them doesn't really work. Whereas like if you have another drink, I'm taking the kids away from you. If you're going to be like it's that punishment sort of situation is the way she described it. And so, yeah, it's so I guess I know this is like a whole long course you would probably have to teach, about how to talk to somebody in addiction, but
Yeah.
like surface level,
Yeah.
how do you talk to people that are, struggling with that?
Yeah. So we use something called positive communication, and there's an acronym PIUS, PIUS. So it's positive eye language, understanding, and share the blame. So there's three different sections of it, but like basically like, I really love and care about you, and it scares me when I see you using in this way or when this or that happens. And I understand that you're really anxious or really stressed or that it's hard for you to stop, but you know, but I really want to be here to help you with that and to think it through. And also, maybe I know sometimes when we get into arguments, you end up drinking more. And so maybe sometimes I'm part of the problem and I'm going to try to work on that also. So it's sort of like talking about it in a positive and supportive way and loving way and caring way, but also sort of, showing understanding and then also potentially sharing the blame.
Yeah, for sure. Um, because there's a lot of, the people that have someone that they're related to or they know that they care about that have had, there's so many people on that since doing this show. Let's go back to this. Since doing this show, like you've accumulated so many different contexts of people who have lived experience, right? And so they sort of have their own realms to the recovery people where they need that support system. And so they have, peer support. They have all these other organizations that they're connected with. They all sort of know each other in these circles. And so, like, but every few days you can scroll through on my social media feed and I see how they're all mourning, like one person that they all knew that overdosed. You know what I mean?
Oh,
Like the fentanyl is just taking over people and like not giving them a chance to even heal. And it's yeah, it's a serious matter. And they're losing people all the time, but that positive reinforcement is huge, and you just don't know how impactful that is, and how, because one slip now can be the end of it, right?
yeah. Yeah, fentanyl is so dangerous. It's really it's so frightening. So if someone's using opiates or using, pills that might be laced with opiates or things like that, we're always talking about Narcan. We're always talking about using things like there's a phone line you can call, never use alone. You call it, and it's somebody on the other line who will uh, sit with you while you're using. So in case you overdose, they'll call 911, so someone will come and rescue you.
Wow, I did not know that was a thing that existed. Okay.
Yeah, so things like that, like, could because it's so dangerous, and we just want to keep people alive long enough to be able to treat them, to encourage them to take. There's a lot of really good medicines for opioid use disorder, and and those medicines are really protective and reduce overdose. So, really encouraging people to consider medications, either Vivitrol or buprenorphine, um, or there's injectable forms of buprenorphine too. There's really helpful medicines that can help and reduce the risk because it is so risky.
Of course. So you founded Whole View Wellness, which has a registered trademark next to it. So is this what your clinic is, or is there more to it? Is this a curriculum that you developed, or what is that? What?
So whole view is sort of like this idea that I had in the back of my head since like the early 90s. So after I was at Yale, I had to get back to New York because I'm a New Yorker. So my mentor at Yale called her mentor at Columbia, and there was a position open, and I applied for it, and I was lucky enough to get it.
Sure.
And so I did research up at the medical school for 4 years at the Substance Treatment and Research Service. And when I was at that job, there was a group of psychologists. We had a bunch of different NIDA funded research projects and people who needed. And if you ever looked at the back page of the Village Voice, and there were like ads for like using heroin, need help, that kind of thing. That was us. We put all our ads in the back of the village, that back page of the Village Voice. And we would recruit people who wanted to get free treatment and be in research studies. And we did a lot of really interesting research studies to learn what worked and what didn't work in terms of treatment. But the group of psychologists that I worked with in that unit was so much fun, and they were so smart, and we were doing such good treatment. I just really loved that job. And I always had it in my mind, if I could just get a group of psychologists who wanted to do this work and do it in the right way, and we could just take this and put it in a clinical setting. Like, wouldn't that be cool? Like, I'd love to do that. But I was like young and just out of graduate school, I had no money. Like, I couldn't do that. But it was in the back of my mind. And then I got recruited to do a welfare to work program in the Bronx, which is basically like when people are applying for public assistance, if they say, I've got a heroin habit or I'm using crack or I'm drinking too much and I can't do workfare, I can't sweep the streets or whatever, they'll excuse them from workfare, but send them to someone for a substance use evaluation and then for treatment. We were a startup that did those evaluations and then referred people for care. And I did that startup for like 4 years, which was really interesting because when I got to the Bronx and I started evaluating people and referring them to all the programs all over the Bronx, I realized how bad the treatment was. It was like shocking because I had been in these ivory towers where people were doing really good high level
Yeah.
treatment. And then I get to the Bronx and like, they're just talking about the weather and the Yankees. They're not helping people at all. Like it was just like bad treatment. Like there was groups were like 30 people. I mean, it was just like chaos and the patients were getting terrible treatment. It was like so upsetting to me. And I was like, oh, wow, this is awful. Like, no one's getting evidence based treatment. No one's getting what helps. Um, and so I did that for 4 years. And then I got recruited to run the division of substance abuse at Albert Einstein College of Medicine, um, which and it's a large treatment system. We had like 3,000 patients. And so I was like, okay, and now I'm going to be able to bring what I know works to like a fair number of people. I can help more people this way. And so for 12 years, I was at that job. It was mostly methadone treatment, and we did like integrated methadone, but we also did HIV and hepatitis C care, and we treated all sorts of medical disorders because patients come a lot. We got grants for like services, and we got grants for, um, HIV services, like all specialty things. We tried to really do a lot of really um, comprehensive care for people because they were coming in a lot to get their methadone. And so we were sort of giving them all the services they needed while they came in. But I found that the hospital system was hard to work in. I wasn't, I felt like I left that place better than it was when I started with them, but it wasn't. Basically, what happened was that people would call me up, friends and family, people who were struggling, who needed help, and they'd say, I've got this loved one who's struggling. Can I send them to your program? And I was like, no, like I don't think my program's good. No, like, and then I was like, why am I running a program that I'm not willing to send my loved ones to, my friends and family to? Like, and I was like, eventually I was like, I'm never going to get there. Like I thought I was making the program better and it was getting better over time, but I'd been there 12 years and it wasn't where I wanted it to be. And I still had in my mind this idea of what had done when I was at Columbia. And I was like, you know what? I'm going to take a chance. I'm going to go and I'm going to try my own thing. I'm going to start my own program and I'm going to do it the way I want to do it, not without the overhead of the administration of the hospital. Like, I want to be able to do it the way I want to do it. And I was lucky enough to be able to start my own program. And 8 years later, we're like growing and, really innovating and doing like really what I think is really high level, nuanced treatment for people. Yeah.
It's amazing.
That's helped you.
Good. So you find it's so different from what anybody else was doing in the area. Um,
There are definitely other people who are doing good work.
sure.
When we started, I basically called up 6 psychologists that I knew from my experiences. And I said, this is what we're going to do. This is how we're going to do it. Will you join me? And they all said yes. And so it was like really exciting and fun. And they like each other and they're all still with me in one way or another. And then we've just grown from there. And um, yeah. And so I lost my train of thought.
So the methods that you're using there at Hillview, are they really different than anybody else that is
Oh,
around in your area? I mean,
yeah.
obviously in recovery, you probably have some layovers, but I mean, right there, the communities that you serve, is it so different? I know you saw a lot of bad treatment that was going on, which has encouraged you to make this the good treatment.
Yeah, I mean, I think, and it's something you actually brought up a little while ago, is like, I think people conflate peer support and treatment sometimes. So peer support is fantastic. I am a huge fan of peers. I think peers are amazing. And like the way I describe it is like, if God forbid I had cancer, um, I would want to go to a peer support group to learn about how to deal with nausea or the medicines or hair loss or like all the things that you have to deal with maybe when you have cancer. But then I'd also go to like an academic medical center and get treatment from doctors who'd been trained to treat cancer, right?
Yes.
So So both of those things are really important and really valuable, but they're different. And I think it's the same thing with addiction treatment. I think it's really great for people to go to peer support and mutual support groups and get support from people who've been through it and who understand it and who can really identify with what they're going through. And then it's also, I think, really important to talk to people who've been trained, who know what medications might help, who know what therapies might help, who can diagnose all the comorbid conditions that are happening, in conjunction with the substance use, what might be driving the substance use. So that's part of it, is that I think it's really important to have, social workers, psychologists, psychiatrists, people who are like specializing in treating this condition, treat it, you know. So there's that. And then those people need to be trained in the therapies that actually work.
Have you seen a big change in the way that people are just generally treating, addiction issues in your field?
I mean, over the many years that I've been doing this since like in various ways since 1995, 96. Um, there's definitely been more support for medication assisted treatment. So people understand that buprenorphine is really helpful for opioid use disorder, that naltrexone or Vivitrol is helpful, that there are 3 FDA approved medications for alcohol use disorder, although they're not being used anywhere near as much as they could be. Um, and I think that there's just more research behind it, so we know, um, we do a lot more trauma informed therapy now than we had back when I first started. And there's a real understanding that trauma can really drive the substance use.
So you've been interviewed quite a bit on several different media types and CBS and everyone else has covered you, and you get covered a lot on Dry January. It seems to be one of the things that you always get interviewed for.
Yeah.
Is that for a particular reason or just happen to be?
And people love talking about dry January. Like, I think there's just so much interest. Well, sober October and dry January are both
Okay.
pretty, pretty, people are interested in it. It's like dry weddings are new.
Yeah.
And I think it's an interesting phenomenon, and I love it. Like, I'm a big fan of it. And so you had said you were curious about community reinforcement approach before. And there's community reinforcement approach is a therapy that was developed by a guy named Bob Myers. He's a psychologist at University of New Mexico. And one of the things that he encourages people to do in community reinforcement approach is sobriety sampling. And what sobriety sampling is just trying sobriety, like encouraging people to give it a shot. Like, what would it be like to not drink for a month? So dry January is basically sobriety sampling, but it's sort of a cultural phenomenon that a lot of people can get behind, and people don't give them a hard time if they're not drinking during January. It's past the holidays, and they might have had like a rough period during the holidays. There's often a lot of like family strife or over drinking at parties and social and family situations. So people are often ready for a break. And it's a time where you can maybe convince somebody to take a month off and just see what it feels like not to drink or use.
Yeah, that makes
You know,
sense.
yeah, it's good to compare, right? Like a
Right.
whole month of not drinking, with what was happening before that, and is it better? Is it worse? You know?
So I guess for the people that are like the binge drinkers, right? And so the heavy drinkers, for them to try something that is completely opposite, because I've had these conversations about cold turkey and like how that can actually have a negative effect on people if they're used to drinking, alcohol for so long. Like my father, right? If he was like, you knew he was awake because you heard the beer can crack open, right? And and that was from the time he woke up to the time he passed out wherever he was at that point. But to just stop and for a few days, are there not risks of any kind of withdrawal? And should they gradually step down or
Yeah,
do
so
they?
it really depends on how much you're drinking. So
Yeah,
the drinking you were just describing from the morning to the nighttime, though somebody who's drinking that much really should not and cannot stop on their own. They should have it should be medically supervised, because if someone who is dependently drinking stops, they could have seizures. They could even die. Like, it's pretty serious. So someone like that really needs to go inpatient typically to detox first, and have medical supervision and medications to help them taper off of drinking. But I think of alcohol as really a spectrum disorder. Everything from I don't drink at all to I drink once in a while to I drink, you know, heavily a couple times a year to I'm drinking all day every day, right?
yeah.
And so, you know, if you're having more than, like, say, I usually look at more like 8 to 10 drinks in a day, that's when you need to start thinking about, like, just
Yeah. Yeah. Yeah, for sure. Yeah, that's a lot to have in a single day. Some people are trying these other types of drinks. I just really recently found out about that sort of subverts that need for alcohol. And so, because maybe like the social drinker, like we were mentioning earlier, because there's different types, right? It's on the spectrum. But some people just drink because they want the social, but then they're also getting the effect of the alcohol. So kava bars have been opening up. I don't know if so, okay, so you know about them. I just found out about this like 2 weeks ago. I still don't know a whole lot about it. Is it, do you think that's beneficial for someone to do, or is there
you
enough
know,
research?
yeah, so I don't know the research on, I don't think there is enough, I'm not aware of the research on that, let's just say.
Yeah,
So I can't really speak to that, but, um, I think I think we need to be careful because I'm just not sure, I guess is
yeah,
what I would say to that.
yeah, because it was something that's not FDA regulated right now. I'm sure at some point, it
Right.
will
Well,
be.
it's not a medication, it's like a supplement or yeah, like a, I'm not sure exactly what category it's in, but it's sort of, and the other one that's like that I hear a lot about is kratom, which is more, so
Yes,
kava is more like alcohol-ish, like more like a benzodiazepine kind of feel, whereas kava is more like an opioid. Sorry, kratom is more like an opioid.
yeah. Which doesn't sound great, right? It doesn't sound like that would be good for you.
Yeah, yeah, and
Yeah.
both of those things you can get them in like bodegas, or you can get them anywhere in the city. Um, and then the other one is nitrous that we see a fair amount where people are inhaling nitrous oxide, which is
Gosh. Wow.
really,
Really?
really dangerous, and I see really bad physical
Yeah.
consequences of nitrous.
I can imagine. Yeah, that's that's awful. I don't want any part of that. I'm good.
Yeah, good.
Yeah. Jeez. It's incredible. Well, yeah. Well, yeah. If people wanted to keep up with, Wholeview Wellness and what you're doing, like, where would they go for that?
And they can come to our website, wholeview.co. We have a blog and we have like some like the news pieces that we're doing are posted on there. They can check that out. Um, if someone's looking for treatment, like if they're wondering, oh, am I struggling with, alcohol? Is alcohol a problem for me, or is my drug use causing a problem? I would just encourage people to reach out. You can talk to your family doctor. There might be medications that can help. You can try an AA meeting or an NA meeting to see what that's all about. That's free, and they have them online, or in pretty much every community across the world. um, or talk to a psychologist or a social worker who's trained in treatment for addiction. There's a lot of different pathways, but like it's good to talk about it, and just start the conversation and start looking at, like, is this something that I could change? Is this something that's causing problems for me? And some people like a medication, some people like a therapy, like people like different approaches, like, but just try something, it would be my recommendation if they're worried.
Fantastic. Yeah. Well, thank you so much, Dr. Church, for joining us and for educating me on a lot of different things. I didn't realize the different acronyms that we were talking about, the different models, and so the community reinforcement is particularly, it's really interesting to me because I haven't heard that from anyone else yet. But it kind of
Yeah,
lines up with principles of things that people are practicing, but I don't think they've given it a name yet.
yeah. So the community reinforcement approach, I didn't really describe it, but basically it's sort of rat park. This idea, I don't know if you ever heard of the rat park study, but it was basically where they had rats in a cage and they gave them water bottle or a bottle with cocaine water in it, and they drank the cocaine water until they died. And they're like, oh, well, people just, they're just drawn to cocaine, and there's nothing you can do. It's sort of like inevitable. People just, like, once they've tried it, they're gonna do it till they die. And then somebody got this idea of, like, put them in a cage with the cocaine water and the regular water, but put other rats in there for them to play with, and put a little wheel for them to play on, and, like, put a whole bunch of interesting things going on in there. And when there was other rats for them to play with and other things for them to do and distraction and fun for them to have, they weren't drawn to the cocaine water. So it was this experiment of, like, you need to fill your life up with meaning and fulfillment and other people, like, so, like, to love and to work, um, to just to draw you away from the substance use. So the community reinforcement approach is basically a therapy that helps people find that meaning and that fulfillment in their life and the things that make them happy and feel good and develop the connections that would compete with their substance use.
Awesome. Yeah, I love that. And I'm definitely gonna do some more research on that. Thank you for letting me know and enlighten me on that. Um, yeah, thank you again, Dr. Church, for sharing your expertise and for educating us here. And thank you for listening and watching. If you're watching this on YouTube, you can find us on any of the podcast platforms of your choice, and vice versa. If you listen to this as a podcast platform, you can find us on YouTube. Search for Long Term, a podcast in recovery. The one thing we always ask about is not subscriptions or comments or any of that. We want you to share this message with someone that needs to hear it, because that's the most important thing, is getting the message to the people that need to hear it. What Sarah Trish talked about here today, her approach and all these different methods that they're using for good recovery. If you know somebody that could stand to listen to learn about what this is, maybe they need that addiction or that recovery, or somebody that's going through the experience with a loved one, then share this message with them. The worst that can happen is they won't listen to it. The best thing that can happen is it can save a life. So we appreciate you so much for watching these episodes, and we will see you in the next one.